Let's warm up for Endocrine 10. First question, what's the number needed to harm? So the number needed to harm is similar to the number needed to treat, only instead of how many people do you have to treat in order to get a beneficial outcome, with number needed to harm, you're looking at how many people have to be exposed to something in order to have one harmful outcome. So to calculate the number needed to harm, you need to know the attributable risk. So you set up the formula for attributable risk as A over A plus B minus C over C plus D. And then once you have this, you can calculate the number needed to harm as 1 over the attributable risk. Next, which class of antibiotics inhibits prokaryotic DNA topoisomerase? That's the fluoroquinolones. All right, time for the lecture.
Welcome to our Step 1 video on diabetes pathophysiology. So we'll discuss diabetes treatment and emergencies like DKA in the next video. People are always asking me why diabetes is an endocrine disorder, because people think of it as a food disease and they don't see it as a hormone disease. But I'm sure you're smart enough to pick out the hormones involved, and of course the most problematic hormone issue being the pancreatic production of insulin. So let's begin with the pancreas. The endocrine function of the pancreas is centered on the islets of Langerhans, which are little clusters of alpha cells that make glucagon, and beta cells that make insulin, and delta cells that make somatostatin. You can also find delta cells in the gastric mucosa and interspersed throughout the intestine. And delta cells aren't the only type of cell that makes somatostatin, it's also produced by various cells in the CNS. So quickly, before we dive into diabetes and the function of insulin, I want to spend just a moment talking about glucagon, which is also important for glucose metabolism. So I like to think about glucagon being sort of the opposite of insulin. So glucagon and insulin are what we call counter-regulatory hormones, which means they act in opposite ways to kind of balance each other out. So the pancreatic islets secrete glucagon when there's hypoglycemia, and glucagon raises blood sugar by stimulating gluconeogenesis and causing glycogenolysis. So you're making new glucose, and you're breaking down glucose that's been stored as glycogen in the liver. And you'll hear more about this in the biochem videos. Glucagon also stimulates lipolysis, so you're breaking down fat and triglycerides to produce ketones, which are another source of energy. So everything glucagon does is aimed at mobilizing stored energy, mobilizing glucose, mobilizing fatty acids to make ketones. And then glucagon also stimulates insulin secretion, because once you've made some more glucose by gluconeogenesis, or you've broken down some glycogen to raise the blood sugar, once glucagon has done its job and raised the blood sugar, you need insulin to get that glucose out of the blood and into the cells where it's needed. So glucagon actually stimulates insulin secretion, and insulin in turn inhibits glucagon. Okay, that's it for glucagon. Let's move on to insulin. So I'm sure you know that insulin is the main hormone that's dysfunctional in diabetes. And you have to understand how insulin works, and particularly its primary purpose, which is this. Insulin allows glucose to move out of the blood and into the skeletal muscle cells and adipose tissue, so that cells can use glucose for energy. And if you remember that, a lot of the other details should fall into place. Okay, insulin is synthesized as pre-proinsulin, which is then cleaved into proinsulin and finally insulin. And in that cleavage from proinsulin to insulin, a piece is cleaved off called the C-peptide, which is a measurable molecule. And this little C-peptide molecule is important diagnostically for a couple reasons. So first, it can help differentiate type 1 and type 2 diabetes, which we'll talk about further on. And second, it helps differentiate causes of hypoglycemia between patients taking too much exogenous insulin, possibly factitiously, versus those that might have an insulin-producing tumor in the pancreas, an insulinoma. So to clarify on this second point, if your patient's taking exogenous insulin shots, there's no C-peptide in that preparation of insulin. So those patients are not going to have measurable C-peptide. But if a patient has an insulinoma and they're producing their own insulin, then they should have a high C-peptide. So moving on, insulin goes through all these cleavages in the pancreatic beta cells and is packaged in vesicles ready to be secreted. And then what triggers the secretion? Well, I think you probably know that the main trigger is hyperglycemia. So the body senses the presence of glucose and it wants to be able to use that glucose, so it secretes insulin to move that glucose out of the blood and into the cells where it can be used as fuel. So let's get cellular here for just a minute, because unlike many cellular things, this glucose-insulin relationship is actually pretty well understood and important, and most of all, could involve a discussion of both the Krebs cycle and the electron transport chain, which I'm sure you're anxious to review again. So first, the beta cell brings glucose into the cell using a glucose transporter protein in the cell membrane called GLUT2. Then that glucose is metabolized aerobically through glycolysis, which causes an increase in ATP inside the cell, where your favorite biochemistry topics come into play, although I'll spare you on those details this time. And this increase in ATP causes some ATP-sensitive potassium channels to close. So when that potassium channel closes, this results in a change in the resting potential of the cell membrane. Normally, that resting potential is about minus 75 millivolts. So when the potassium channel closes, potassium can no longer pass as freely through the cell membrane, so that cell depolarizes towards 0 millivolts. And as the cell depolarizes, that causes voltage-gated calcium channels to open. Then, calcium moves into the cell. And we've said before that calcium is often what makes things happen in the cell. In Pharm Basics, you heard about the release of neurotransmitters like acetylcholine and norepinephrine. This is a similar mechanism to the calcium-mediated release of vesicles in the neurons, so they can dump the neurotransmitter into the synaptic cleft. Well, here, calcium does the same thing. It triggers exocytosis of vesicles. So if insulin has been pre-made and pre-packaged in these vesicles, then when the calcium enters the cell, it releases that pre-packaged insulin. So this whole process explains how a rise in extracellular glucose can trigger release of insulin from the beta cells. Now, I mentioned the GLUT2 transporters, which are responsible for bringing glucose into the beta cell. There are actually several different types of glucose transporters in different parts of the body. So the GLUT2 transporter is found in the beta cells and also in the liver, the small intestine, and renal cells. This is an insulin-independent transporter. Then there's a GLUT4 transporter, which is found in adipose tissue and skeletal muscle. This is an insulin-responsive transporter. So insulin is required in order for these GLUT4 transporters to allow glucose to enter skeletal muscle cells and adipose tissue. Remember, that's the main function of insulin you should remember, to allow glucose to be taken up into skeletal muscle and fat cells. And then there are also GLUT1 receptors, which can bring glucose into the cells without insulin. The brain and red blood cells are particularly rich in these GLUT1 receptors, which allows the brain and the red cells to be capable of taking up glucose even without insulin. And this is important because red blood cells have no mitochondria, so they have to have glucose for energy, and they depend on anaerobic metabolism for energy. Other tissues that don't require insulin for glucose uptake include the intestine, cornea, kidney, and liver. So basically all those tissues that don't have a GLUT4 receptor are able to get glucose into the cells without insulin. So how does insulin move glucose from the blood to the tissues? Well, the beta cell releases insulin into the blood, and then insulin travels to various target organs like skeletal muscle, and it binds to an insulin receptor on the muscle cell. That insulin receptor is a tyrosine kinase, so it phosphorylates tyrosine residues on various enzymes that serve as second messengers. And I'm not going to review all the different second messenger pathways here, but you definitely need to remember that the insulin receptor is a tyrosine kinase. But those second messenger pathways can cause the muscle cell or the fat cell to insert more GLUT4 transporters on their cell membranes so that glucose can enter the cell more easily. So that's how insulin allows glucose to enter the skeletal muscle cells and adipose cells. And now, besides that main function of insulin, it does a lot of other important things too. It increases glycogen synthesis and triglyceride synthesis. So again, it kind of has exactly the opposite effect of glucagon. Glucagon causes glycogenolysis, insulin causes glycogen synthesis. Glucagon causes lipolysis, where you're breaking down triglycerides. Insulin causes triglyceride synthesis and storage. Insulin also causes protein synthesis. So these are all called the anabolic effects of the insulin, building big complex molecules out of smaller molecules. And now we're ready to talk about diabetes mellitus, which is a disorder of insufficient or inadequate insulin. And diabetes is a very important disease, very prevalent in the United States, very high yield. I'm sure I don't need to tell you this. On the whole, diabetes is a 5-star topic. You'll have several questions about diabetes and treating patients who have diabetes and other acute problems. So you definitely need to know the ins and outs of diabetes. So how does diabetes present clinically? Well, when people have inadequate insulin, they can't move glucose out of the blood into the tissues, right? So the glucose just stays in the blood and they get hyperglycemia. That's probably the single most important feature of diabetes and consequently the diagnostic criterion, hyperglycemia. then when there's hyperglycemia, people start to get the polys. So the extra glucose gets dumped into the urine where it acts as an osmole and draws water into the urine, so patients will have polyuria. And then they're losing free water and will be thirsty, so they have polydipsia, and they're losing calories because instead of glucose getting into the cells and being used, it's getting dumped into the urine, so they have polyphagia and weight loss. And there are two distinct types of diabetes, and over the years they've gone by a variety of names: juvenile diabetes, insulin-dependent diabetes, etc. But nowadays the names have been consolidated to kind of the two pathology types, distinguished as type 1 diabetes and type 2 diabetes. And they share some complications, and obviously both involve hyperglycemia, but in other ways they're totally different diseases. So we'll talk about the distinctions between them. And first I want to make a point about the emergencies potentially associated with each type. So patients with type 1 diabetes can get diabetic ketoacidosis, or DKA, and we're going to talk about DKA in detail in the next video. But for now, just remember that although there are ketosis-prone type 2 diabetes patients, generally it's associated with type 1 diabetes. And most of the time in type 2 diabetes, the hyperglycemic emergency is hyperosmolar hyperglycemic state, or HHS. This goes by lots of complicated names like hyperosmolar non-ketotic state or hyperosmolar coma, but both DKA and HHS are very severe, dangerous complications of diabetes, and sometimes patients with no history of diabetes whatsoever can present with one of these. So DKA or HHS may be the first presentation. Now let's go into a little more detail on the two different types. So it's very important to understand the fundamental difference between them and to be able to differentiate them clinically. And I will say that there are some cases where it's a little difficult to make the call on the diagnosis because there can be some overlap of some of the features. However, once you understand the concepts, then you can come up with a smart treatment plan either way. So type 1 diabetes is caused by autoimmune destruction of beta cells. It's associated with an islet cell antibody, usually the one against GAD, glutamic acid decarboxylase. Remember that. Once the beta cells are destroyed, they can't make insulin anymore. So in type 1 diabetes, there's primary insulin deficiency. Type 1 diabetes tends to have its onset in younger patients, kids, teens, young adults, and they tend to be non-obese, although now that obesity is so common, it could go either way. Many times these patients are otherwise metabolically normal. And surprisingly, type 1 diabetes is not as hereditary as type 2, although it does have association with HLA genes on chromosome 6, specifically HLA-DR3-DQ2 and HLA-DR4-DQ8. So as I said before about type 1 diabetes, the acute complication we worry about is DKA. We're going to pick that up in the next video, so I'm going to move on. Type 2 diabetes is caused by insulin resistance, followed by inadequate insulin production by the pancreas. So early on, there's lots of insulin around, but the cells of peripheral tissues are not responding to the insulin signal to move the glucose into the cells. This is insulin resistance, the opposite of insulin sensitivity. So as the pancreas is trying to overcome this insulin resistance, it's producing lots and lots and lots of insulin, and eventually the pancreas kind of wears out and can no longer keep up with the demand for insulin. Usually it continues to make some insulin, although not nearly enough, which is more or less a beta cell failure if a person has type 2 diabetes long enough. So type 2 diabetes tends to have its onset in middle age or older, and most patients, about 7 out of 8, are overweight or obese. It's very hereditary. In type 2 diabetes, patients often have other metabolic problems as well, like high cholesterol and triglycerides and/or high blood pressure, and they can also have a skin finding called acanthosis nigricans. So acanthosis nigricans is that dark velvety skin lesion on the flexural areas of the skin, like the back of the neck or the axillae. It can be associated with some visceral malignancies too, but most commonly with insulin resistance and type 2 diabetes. So let's spend a moment on diagnostic testing. Even though type 1 and type 2 diabetes are different in etiology, they both manifest with hyperglycemia, which makes diagnostic testing more or less the same. So for patients with clinical manifestations early on, like the polys I mentioned before, this probably is going to lead to proper diagnostic testing sooner rather than later. And then the other situation is the patient with mild hyperglycemia. These patients may not have any symptoms at all, but fortunately routine labs often include a random glucose, which can lead to appropriate diagnostic testing. So what is the appropriate diagnostic testing? Well, there are a couple of types. So there are glucose-based tests, fasting serum glucose or 2-hour glucose tolerance test, and the hemoglobin A1C, which is more of an average glucose over a few months. So the glucose-based tests are pretty self-explanatory. Either the glucose is high or it isn't. But let's talk a minute about the A1C. So this is a little moiety on the hemoglobin molecule. And as it floats around in the blood, glucose sticks to it in a non-enzymatic reaction called glycation. And the more glucose around in the blood, the more it gets stuck to the hemoglobin. So we can measure the percentage of surface area covered by glucose, which is what we call the A1C. It gets reported as a percentage. Often we use some combination of glucose-based testing and A1C to diagnose diabetes, and we mostly use the A1C for surveillance once the diagnosis is made. And it is nice because patients don't have to fast for it, and it correlates with the average blood glucose nicely, as well as the risk for complications, which of course is what we're worried about in the first place. Okay, so let's move on to discuss these complications. Now, the big problem with diabetes, the reason we treat it, is that hyperglycemia causes a lot of complications. And there are two basic mechanisms that cause damage to tissues in diabetes: non-enzymatic glycation and osmotic damage. So let's talk about non-enzymatic glycation first. So we've already talked a little bit about glycation with the A1C before, where glucose gets tacked onto things not by enzymes, but non-enzymatically. So in addition to glycation of hemoglobin, you can have glycation of blood vessels, especially small vessels, which leads to two problems: retinopathy and nephropathy. And I like to think about this as too much glucose in the vessels sort of scraping holes in the vessel walls and making them leaky. Although this isn't entirely true physiologically, but it helps me remember what we see in the tissue, which is leaky vessels. And let's start with diabetic retinopathy, which is damage to the retinas. And this starts out just with the leaky vessels when it's called non-proliferative, and then if it progresses, it might become proliferative retinopathy, where fragile new blood vessels form in the eye because these new vessels are fragile and they can break, and that causes hemorrhage, which in worst case leads to blindness. So here's a picture of the fundus of a patient with proliferative retinopathy, and you can see some tiny, delicate new vessels forming, and lots of these dot and blot hemorrhages, and some larger flame hemorrhages. And you also see some small, well-defined yellowish blotches, which are hard exudates. And there are other diabetes-related retinal problems besides vessel proliferation, and you might see macular edema and soft exudates, which are called cotton wool spots. And now cotton wool spots are not specific to diabetes. You can see cotton wool spots in a lot of other diseases, including hypertension and AIDS. People with diabetes are also at increased risk of cataracts and glaucoma, which are eye diseases, obviously, but not technically retinal disease or retinopathy, and occur by a different mechanism. But it suffices to say there are lots of different eye problems that are associated with diabetes, many of which can be asymptomatic early on, but can be treated at these stages, and that's the reason people with diabetes should receive an annual dilated eye exam. And then the other complication due to non-enzymatic glycation of small vessels in diabetes is diabetic nephropathy, which of course is kidney damage. So think about all the vasculature in the kidney, afferent arterioles and the glomerular capillaries and the efferent arterioles. So lots of small vessels in the kidney that can be damaged. And glycation of all those small vessels in the kidney causes leakiness, which manifests first with proteinuria. It starts out as microscopic proteinuria and gradually gets worse and worse, so this is progressive proteinuria. And ACE inhibitors or angiotensin receptor blockers can reduce the progressive proteinuria, and you'll hear about those drugs specifically when you hear about CHF and hypertension, but remember that ACE inhibitors and ARBs are good in diabetes. And then you should also remember Kimmel-Steele-Wilson nodules, which you see here. This is a renal biopsy of a patient with diabetic nephropathy, and you see just a few of these acellular nodules in the glomerulus. It can look a lot worse than this. This kidney isn't that bad yet. And then, in addition to damaging small vessels, diabetes can also contribute to atherosclerosis in large vessels, which can lead to coronary disease and cerebrovascular disease and stroke and also peripheral vascular disease. And in the worst PVD cases, patients can get dry gangrene, which could lead to amputation of toes and feet. So this large vessel disease certainly is not specific to diabetes, so clearly there's more to this than just glycation, but it is a contributor. So diabetic retinopathy, diabetic nephropathy, and vascular disease are all examples of complications caused by or contributed to by glycation. And parenthetically, there are at least 5 described biochemical mechanisms that contribute to oxidative stress and subsequent diabetic complications. And while this is really interesting, it hasn't been heavily tested historically. I'm going to talk about one more mechanism here that has been in some questions, and it's the polyol pathway, which relates to sorbitol and osmotic damage. So sorbitol is an alcohol sugar, an alcohol form of glucose. Glucose is converted to sorbitol by the enzyme aldose reductase. That's important. Make sure you know that enzyme. Some years ago, there was a fair amount of drug development energy directed at inhibiting aldose reductase, and unfortunately it wasn't successful, which speaks to the complexity of the damage that's occurring with hyperglycemia. But anyway, once aldose reductase converts glucose to sorbitol, then sorbitol can be converted to fructose by sorbitol dehydrogenase. But there are lots of tissues that don't have sorbitol dehydrogenase or don't have it in amounts sufficient to process all the sorbitol that appears with hyperglycemia. So then if they're not able to convert that sorbitol to fructose, that sorbitol is trapped in the cell. So if the tissues that have aldose reductase but do not have a correspondingly sufficient supply of sorbitol dehydrogenase are Schwann cells, the lens, the retina, and the kidneys. So in these tissues, sorbitol becomes trapped in the cell. And just like we said that glucose acts as an osmole in the kidneys, sorbitol is also an osmole. It causes osmotic pressure that draws in free water. So the sorbitol is trapped in the cell, and then free water is drawn into the cell, and that causes swelling and damage to the cells. So it's important that you know these enzymes and know the tissues that are relatively deficient in sorbitol dehydrogenase and are therefore sensitive to osmotic damage from sorbitol. Okay, so going back to diabetes and the complications caused by osmotic damage. Osmotic damage affects the Schwann cells, so it causes neuropathy, motor, sensory, and autonomic neuropathy. And commonly, patients can have numbness that begins in the tips of the toes and it progresses proximally. So it can begin in the toes and the soles of the feet, then progress to involve the entire foot and the lower legs. So the reason we do monofilament testing in people with diabetes to make sure they still have protective sensation is because this neuropathy can be asymptomatic. And patients with asymptomatic neuropathy need to take special care to look at their feet often and make sure there aren't infections or wounds. People can also lose vibration sense and proprioception, so you can check for that with a tuning fork for vibration and by moving the toes up and down for proprioception. Then you also want to check and make sure people don't have any sores on their feet, because sometimes these patients with neuropathy can't feel that there is a wound on their foot, and that wound can get infected, which is the beginning of how people lose limbs from diabetes. Patients can also have painful neuropathy, which can be almost anything from restless leg syndrome to uncomfortable tingling sensations in the feet or prickly pain like pins and needles. And this can be extremely painful and can be very difficult to treat. And there are a lot of drugs we can try to help with neuropathic pain like gabapentin, duloxetine, pregabalin, amitriptyline, and then several others. All right, diabetes is just too big a topic for one video, so that's all I have for this video. We'll do the end of session quiz, and then we'll walk through the answers. All right, first question. How is hemoglobin glycated in diabetes? It's a non-enzymatic glycation that's taking place, and the key point is that it is non-enzymatic. Next, which type of diabetes mellitus fits the following descriptions? Associated with obesity, that's type 2, may cause ketoacidosis, is primarily type 1, strong genetic predisposition is type 2, but the one that's associated with HLA-DR3 and DR4 is type 1. Next, in which tissues will you find GLUT2 receptors? The beta cells of the pancreas, the small intestine, liver, and kidney. And the last one, which tissues depend on insulin for glucose uptake? These are the skeletal muscle cells and the fat cells or adipose tissue because they have those insulin-dependent GLUT4 receptors. All right, that's it for our video on diabetes. I'll see you soon.